morning to all. Now, optimizing cataract surgery outcome through biometry, a practical approach. Now, Dr. Warren Hill, in his data entry from over more than 260,000 eyes, has shown that only 1% of surgeons achieved an accuracy of a target refraction of within 0.5 diopter in 92% of eyes, and the majority of surgeons attained this in around 78% of cases only. So with newer methods, today we can achieve around 90% of accuracy of within 0.5 diopter of target refraction in 90% of patients. Now, Nobi et al. In 2008 studied the source of error in the refractive outcome of cataract surgery and found that the preoperative estimation of the accuracy of the estimation of effective lens position was the most common source of error, followed by postoperative refraction and axial length measurement. But now things have changed. Axial length measurement is no longer a limiting factor because of the superb accuracy of optical biometers, and effective lens position is still the commonest source of error. Getting accurate keratometry is another problem because we need to validate the data, you have to optimize the ocular surface, and you should look carefully at the Myers for their clarity. Now, getting good keratometry measurements is possible with optical biometers, but in unusual eyes, as in case of post-refractive eyes and in steep and flat corneas, this may be supplemented with topography. Now, we need to validate the measurements of optical biometers, and then if any of the measurement is not good, we need to measure it again, and this will save us from a lots of trouble. Now, having taken good measurement, we will move on to IOL power calculation formulas. Dr. Douglas Koch has classified formulas based on their method of derivation and the data they use for these, and these are obsolete. And Virgin's formulas, they are based on Gaussian optics, and Barrett Universal 2 is based on 5 variables, that is axial length, keratometry, anterior chamber depth, lens thickness, and white to white. And Holiday 2, in addition to these, uses preoperative refraction and age of the patient. Now, Olsen formula, which is a ray tracing formula, it takes into account the entire optical aberrations of the eye, including that of the cornea. It also takes into account the shape of the IOL and the sphericity of its anterior and posterior surface. Now, Hill RBF formula is an artificial intelligence based formula. It also uses regression analysis of the postoperative refraction of the patient and then uses pattern recognition to arrive at the correct IOL power. And the latest version 3 that was published in December 2020, it gives accurate measurement for IOL powers ranging from -5 to +34. Now, the Kane formula is a theoretical formula, but it also uses artificial intelligence. Today, the two most popular formulas are the Barrett Universal 2 and Hill RBF. And we have got an upcoming super formula that is Kane formula, and the future may be Olsen because it takes into account the entire optical aberrations of the eye. Now, the older formulas, they were based only on axial length and keratometry measurements. They were based on thin lens optics, and they fairly worked well in normal eyes, that is axial length between 22.5 and 24. But the newer formula, they take into account more measurements like anterior chamber depth, lens thickness, etc. And they are based on thick lens optics, and they use artificial intelligence and regression analysis of postoperative refractive outcome and pattern recognition. And these are useful for outliers, that is long axial and short axial length eyes. Now, Kane et al. In his review of over more than 37 studies that was conducted over more than 50,000 patients, he conducted this review to find out which is the most accurate biometer and which was the most accurate formula. And these are the formulas that were used, that is Barrett Universal 2, Hill RBF 1 and 2, Holiday 2, Olsen, Kane, etc. The Hill RBF version 3 was not included in this study. So they came to the conclusion that the Kane formula was the most accurate formula of all IOL formulas, and the Barrett Universal 2 and Olsen formulas, they have been shown to be the next best performing formulas. Now, the short axial length eyes pose a major challenge because a small error in the estimation of ELP will cause a major shift in the refraction because of the large power of the IOL. So if we have got only older generation formulas, we can use either Hages or Fokker-Q. But 2-3 large studies on short eyes have shown that the Kane formula was the best formula even in very short eyes. So if that is not available, we can use either Olsen, Hades, or Holiday 1 or Hopper Q. Now coming to the long eyes, this is less of a problem because the IOL power is low here. So even in myopic eyes in this review, the Kane formula was the best formula, and this was followed by Olsen, Barrett Universal 2, and Bangkok modification of Holiday 1. Now coming to the biometry devices they reviewed. So most of the biometers, they achieved outstanding levels of reproducibility and repeatability in spite of the difference in their mechanism of operation. And average measurements obtained were strikingly similar between the devices. And even the greatest measurement difference, they did not change the IOL power that was selected initially. So the main difference between them was their ability to measure the axial length through dense cataract, where SSOCT devices definitely scored over PCI or OLCR based devices. So the surgeon's preference may depend on other commercially available features like speed and use of operation. Now optimization of A constant has shown to improve the refractive outcome after surgery. Now initially we can use the manufacturer's A constant and later we can optimize it. IOL Master 700 has got an option to do this, and latest A constants are available in direct online calculator also. We also should be aware of the potential difference between the actual and the labeled power of the intraocular lens. Now, we must have done our best, but things can go wrong. Kinshan et al. Has shown that in 17% of patients, the anterior chamber depth shifted by more than 1 millimeter from 1 to 2 months postoperatively, and this produced a change in their refraction. Now, in some cases, like PCR, we may not be able to place the lens inside the bag, and we will have to place it in the sulcus. So, in such cases, we need to reduce the power of the IOL accordingly because the effective lens power increases as we move forward. And if you are doing an optic capture, we can use the same power IOL. Now, coming to the second eye modification, if we have a refractive surprise in the first eye, we should first check the reliability parameters. We need to repeat the biometry, and we should see whether the right IOL was implanted in the patient. If all these things are, if these things are correct, then adjusting a 50% of the first eye prediction error increases the refractive accuracy of the second eye. That is, if the first eye was left 1 diopter hypermetropic, we can aim for 0.5 diopter of myopia in the second eye. Now we need to take into account other things like what's the refractive status of the other eye, whether that eye is a high myope or not, and also you should assess what is the worst pattern of the patient. So to summarize, optical biometers should be used if this is accessible, and Subsos OCT-based devices can measure axial length even through very dense cataract. Biometry measurements need to be validated. Newer formulas like Barrett, Hill RBF, or Kane are robust throughout axial length and can be used without any adjustment. Be mindful of adjustment for sulcus implantation. Second eye refinement can further improve accuracy, and you need to do updates. Thank you.
Thank you, doctor. I have a couple of questions. One is I wanted to know where do you access this Kane formula?
It's there as an online calculator. As far as I know, it is not available in any of the biometers, yes, but it is there online.
Yeah. So similar to the ACRS calculator, we have it online. I just wanted to make that point. And which formula do you routinely use in all your general cases?
I always use Barrett suit. That is the Barrett Universal 2, Barrett toric calculator, and the Barrett TrueK for post-refractive. All Barrett suits.
Okay. So that also is available online?
It's available available online, ACRS website, APCRS website, it is available, and the Lenstar, IOL Master, everywhere. So.
Thank you.
Yeah, Kane formula that is available online. Actually, it's an upcoming formula. The newer studies have shown that it is very accurate, and it's basically it's an theoretical formula, but uses artificial intelligence also. So it takes into account basically the axial length, keratometry, ACD, and also the gender of the patients. And then it has some artificial intelligence algorithm also. It's available only online. As far as I know, it's not available in any of the biometers. Yeah, it's free.
As per the latest literature which I read, I think Kane and Barrett 2 are more or less equivalent. Kane used to be better with keratoconic eyes, and now the Barrett TrueK is giving you the same results as the Kane for the keratoconus as well.
Barrett,
so either or is good
Barrett TrueK, I think it is for post-refractive eyes.
No, now latest one.
He has got a Barrett calculator for keratoconus eyes also
so
separately.
On our, I use the Argus. So in the Argus, if I go and press the keratoconus as the choice, as the pre-existing disease, it directly converts to a Barrett
Barrett,
through cane.
yeah. Oh, thanks.
And I wanted to know how often you calibrate your iron master. You were mentioning about calibration of instruments, no? In routine practice, do you really calibrate the iron master very often, or is it not required?
That is the optometrist. Actually, it's not required very often, but I think they are doing it in once in 6 months or so.
Have to clarify.
So, which are the cases you would actually consider putting in the posterior readings in the formula? Yeah,
Posterior astigmatism.
posterior
So
astigmatism,
usually for
measured
routine
ones.
cases, we don't take it into account, but for toric IOL definitely. But this Barrett toric calculator has got inbuilt algorithm to calculate the posterior corneal astigmatism also. So we don't have to use it separately. But that is all the more important because in case of post-refractive eyes, means unusual eyes, outliers, we definitely take. Otherwise, for normal toric also, we don't use TK, we usually use toric calculator. One important thing is, if you're using Barrett toric calculator, you should not use TK because then there will be 2 times posterior corneal astigmatism will get added up because the original toric itself has got a correction factor. Then if you're using TK, then there will be double correction.
Here I would differ a bit. Maybe in oblique astigmatisms, I would actually put in measured posterior corneal curvatures for a routine case as well.
Thank you so much.